All right. So we got this. Doing diabetes. Diabetes time. I'm going to share the screen. We're going to get started in just a moment. Let me just send the link out. For those of you guys who are watching, oh, we've already got 3 people watching. For those of you guys who are watching, we are only going to be doing material, and then we'll do a second recording so people can actually watch just questions later. There you go. We got some new people on here today, so let's see how it goes. Now this should be all up to date and ready to roll. We got new pictures on this. And we're talking about diabetes. So, diabetes, chronic multi-system disease, mostly relating to hyperglycemia. Why do we have hyperglycemia in a diabetic?
Not enough insulin secretion?
Not enough insulin, or?
Inability for the cells to use the insulin.
Or a combination, depending. But defects in the insulin secretion, insulin action, resistance. Who has an increase in prevalence of this occurring?
Minorities and elderly?
Yep. Native Americans, African Americans, elderly, Latinos. Pictures here to kind of remind you about what we're talking about today. Type 1s. There's no insulin. Sugar can't go in there. No pathway. Our type 2s have the insulin, but our cells aren't listening. We'll go over all this, so this is just a kind of general review of that picture on your right. Oh, we can't do anything yet. You know what we're missing, right? The laser. Gotta have the laser. So, this is showing you the blues. This is your type 1. Lethargy, stupor, weight loss, nausea, vomiting, abdominal pain, Kussmaul's. So, now, who has ketones when we're talking about diabetes?
Type 1.
Type 1. So what's the problem with the ketone?
It's the body breaking it down. The protein.
Protein and
Adipose.
adipose. You have your adipokines, right? Ketones are acidic. That's an issue. We don't like acid. We like to stay in a nice 735 to 745 range, don't we?
Yes, we do.
And that's not where we stay. If something comes in and starts being acidic, we don't like to change. So, diabetes, high blood sugar. If we have a lot of blood sugar, what happens to our circulation?
Slows down.
Slows down. Platelets begin to stick together. White blood cells begin to slow down, which of course increases the risk of infection. If our platelets are sticking together, what happens at our capillary beds?
Can I get oxygen?
Yep, we get a little cloggy. Look at that, clogging up. We don't like that. We're going to have macrovascular circulations, micro and macro, but we're going to have microvascular circulations. Our issues for microvascular issues, what are the 3 microvascular issues?
Neuropathy, retinopathy, and nephropathy.
Yep, retinopathy, neuropathy, nephropathy. So, we got eyeball issues. We got nerve issues. We got nephron issues. And don't forget, it's long-term. Leading cause of, you just think about what we just talked about, blindness, renal disease, lower limb amputation, specifically non-traumatic end-stage and adult blindness. Major contributing factor to heart disease, hypertension, stroke. We have to start thinking about macrovascular complications as we keep going, though, right? Because macrovascular gives us a lot of atherosclerosis. So if we start thinking about that, what's our 3 big macrovascular issues?
Stroke,
That's part of it, but what are the letters?
CVA,
So what's that?
cerebral vascular.
So you got to say it.
Accident.
Coronary artery disease, peripheral vascular disease, cerebral vascular disease. So, we've got a couple sayings to help us with this. Hot and dry means you're high, cold and clammy, you need some candy. Talking about hyper and hypoglycemia. These are just some things to help us think about them. You know, when we're hyperglycemic, your symptoms. You need to urinate, polyuria, dry skin, hunger, drowsy, blurry vision, and then you know how to handle it, call your provider. Hypoglycemia, shaky. This is a big one. It's irritable, dizzy, anxious, sweaty. Alright, your etiologies of hyper and hypo. With hyper, you have an increase in food, hypo, a decrease. If you're hyperglycemic, what could be happening with your insulin levels?
What'd you say?
If you're hyperglycemic, what could be going on with your insulin
They're
levels?
low.
They're low. Or they could be normal, and they just could be resistant. But this is just general hyper versus hypo. In hypo, you think insulin, or increased insulin, or other oral anti-diabetic meds. Illness and stress can cause hyper. Excess exercise can cause a hypo. Now, hyperglycemia, are we going to see that gradually or suddenly?
More gradual.
Yeah, it's a gradual onset. You have a sudden with hypoglycemia. And remember, you're going to see hypoglycemia and watch for this, the peak of your insulin. Hyper, you think about 126 or greater with your fasting blood sugars. What's your skin going to be like if you're hyperglycemic?
Dry.
Right. Pruritus. What's it going to be like in hypo?
Muddy.
Diaphoretic.
Ready.
Yeah, diaphoretic. Cold, Tammy. Need some candy. Both of them, nausea, some hunger, drowsy, blurred vision, impaired vision. Polyuria, polydipsia, hyper. Combative, irrational, anxious, tachycardic, palpitations. Headache, dizzy, tremors, numb, lips, tongue. Treatments on our hyper, you got above 250, we need to call the doctor. We've got our hypo. Again, your fast-acting carbohydrates, OJ. Several hard candies, test that blood sugar. Call that doctor if the signs don't stop. And once we get it to normal levels, eat within a minute, an hour. Make sure we keep it up there to the complex carb, peanut butter, meat sandwich. All right, if we want to diagnose diabetes, what's the test we want? They're right here. Fasting blood sugar, above what numbers?
Of 126.
How often?
More than once.
Twice.
At least twice, right? What about our random?
Above 200.
Polyuria, polydipsia, above 200. Then our postprandial.
Above 200.
You have your fasting blood glucose, you have a glucola, the 2-hour wait, still above 200. Now, insulin. What is insulin? Besides an anabolic steroid, therefore it's easy to gain weight. What is it?
Hormone.
It's a hormone. Where is it made?
Pancreas.
Beta cells.
In
The islet.
islets. How often is insulin released?
Continuously.
Continuously, to maintain that 70 to 120, right?
Yep.
What hormones are released that oppose the effect of insulin?
Glucagon.
Cortisol,
Glucagon, cortisol.
epinephrine, and your growth hormone.
Ooh, look at that. Like, I think we have to know these from somewhere else. General idea of your insulin releases. Now, what's the main purpose of insulin?
Transport and metabolize glucose for energy.
Yep, get it in there. We want it to store it as well, right? The liver, the muscle. How do we store glucose?
Glycogen.
Glycogen. We have phosphorylate it, it becomes glycogen. What do we use to break up glycogen so we can use it again?
Glycagon.
Look, there's not a glycagon.
Glucagon.
Glucagon?
Glucagon.
Glucagon, yes. Signals the liver to stop the release of glucose, enhances the storage of dietary fat, accelerates the uptake of aminos. One more big one, inhibits the breakdown of stored glucose, proteins, and fats. So we have to have insulin so we don't do that. So what happens if we don't have insulin? What do we get?
Adipokines.
Ketones, right? Fat and protein breakdown, ketones. Is your general idea of those? Now, your type 1 versus your type 2s. Type 1, TKA, Kussmaul's, lacking of insulin, thin. Your type 2s, you start thinking of your hyperglycemic, hyperosmolar, non-ketoic syndrome, insulin resistance, obese. Remember, type 2, the #1 killer is a silent MI. One doesn't feel the symptoms of an MI. Risk factors of a type 1 diabetic. What is it? Genetic, for the most part. Type 2, we've got central obesity, BMI over 30, high blood sugar, genetics, of course, gestational history, hypertension, and of course our race is Black, Native American, Latino, and elderly. Now, what age are we looking for in a type 1 diabetic?
Below 30.
How quickly does this show up?
Acute.
Sudden onset. What are the 3 symptoms these patients will probably show?
The 3 Ps.
They show up with 3 Ps.
They certainly do.
Polydipsia?
Polyuria. Polyphagia.
Yep. And they, of course, require insulin. What age are we looking for in a type 2?
Over 30.
Over 30. And what are our metabolic abnormalities that can cause this?
Insulin resistance.
Insulin resistance or decreased insulin sensitivity.
Beta cells aren't working, so they can't produce insulin.
Hypoinsulinemia or low insulin because of damaged beta cells, right?
High glucose production.
Yep. The inoperative glucose production. Inappropriate production, and you said it 4 times, Jenna.
Adipokines.
Hey!
Yay!
Alteration in production of hormones and adipokines. Big symptom of a type 2 that increases their risk is what?
Weight gain.
Obesity. Yep. Insidious onset, they're going to have the same symptoms, but they're going to blame their symptoms on what?
Being out of shape.
Being older.
Everything else, basically.
That if they're not diagnosed, they're like, oh, I'm getting older, you know. This is just your general idea of a type 2. Another one of these, everything breaks down, you get your glucose, it gets in there just fine, you make your insulin, doing great, but your cells aren't listening to you, and that's the problem. Now, Secondary. What is this related to?
And medications such as steroids.
Mm-hmm. Long-term glucocorticosteroids, right? Impaired glucose control related to another factor. So we have these, we're like long-term, and we now need to take them off of this. How do we take them off glucocorticoids?
Taper.
Taper them off of it slowly. And if they're taking these steroids, what do we need to make sure they take along with them?
CPI.
PPI, H2 antagonist, and make sure they don't take any NSAIDs. GI issues. What's our blood sugar level of our pre-diabetics?
100, 125.
What's our symptoms of a pre-diabetic?
There's no symptoms.
No symptoms. What is our treatment for these patients then if they have no symptoms?
Education.
Education. We're educating them about the exercise they need. Their diet, C5, F2, weight loss, 50% carbs, 20% fat, 10% protein, and based on 10, 50, 60, 20, 30, 10, 20. They need to get themselves down so they don't go in and start damaging. The other type, what type of diabetes does a pregnant woman get?
Gestational.
Gestational, kidney cancer store. You've got hormones that are still counter-regulatories, estrogen, cortisol, HPL, human placental lactogen, all produced by the placenta. The body's not going to listen to the insulin because of it, and all that sugar goes to baby. Does baby have insulin?
Yes.
Baby has lots of insulin. Baby's going to take it and go nice and big, becoming what?
Macrosomal.
Macrosomal, right? Increasing your risk of getting what type of emergency labor?
Shoulder dystocia. C-section.
C-section. But we can have a shoulder dystocia. Oh, you guys were thinking I was going to ask the same question. Yeah. You can have a C-section because of shoulder dystocia, or it's a macrosomic baby, cephalopelvic disproportion, but we have an increased risk of going to that C-section. Now, if you have gestational diabetes, are you going to need insulin?
Yeah.
You're going to need something to control it, aren't you? What do you probably have an increased risk of happening when you get older?
Type 2 later in life.
Blue, type 2. Remember, slow progressive glucose intolerance. Excess adipose will interfere with your insulin. What syndrome increases your risk of this?
Metabolic, no, yeah.
Yes, metabolic syndrome. Insulin resistance, hyperinsulinemia, high LDLs, low HDLs, hypertension, male waist over 40, female over 35, inch waist. What's our initial treatment for a type 2 diabetic?
Diet and exercise.
Hey, look at that. Of course, your oral hypoglycemic agents may also be used as well as insulin. What body type is more likely to see this?
Overweight.
Your apple bodies. Yep. Risk of your coronary artery disease goes up with this. Central obesity. So, let's talk pathogenesis. What can your pancreas do to cause you to become hyperglycemic?
Not produce enough insulin.
Yep. Insulin's not being secreted. That can cause you to become hyperglycemic. What can happen in your GI tract that can cause you to become hyperglycemic?
You're eating too much.
Yep. Absorption of glucose. What happens in your muscles? That can cause you to become hyperglycemic. Or your tissues.
Breakdown.
Decreased insulin stimulated glucose uptake. So you have the sugar there and they stop taking it in, the sugar stays there. And of course your liver increased basal hepatic glucose production. Now, I'm going to jump through these really quickly because this is just a quick review. Your 3 Ps on type 1, polyuria, polydipsia, polyphagia. Why are you hungry if you have a high blood sugar?
Because your cells want that energy.
Yeah, but there's blood sugar there.
It's not taking the blood sugar in.
Oh, I didn't know that. Thank you. Fatigue, weakness, sudden unexplained weight loss, 5% of normal body weight, or 10 pounds or greater in 6 to 12 months without trying. What is the big symptoms of DKA? Showing you an acute issue, type 1.
Abdominal pain.
Abdominal pain.
Vomiting.
Abdominal pain is your big one. Leads into your sudden weight loss because of nausea, vomiting, right? 1 liter of fluids a kilogram, 2.2 pounds. So there's your sudden weight loss. Abdominal pain. Of course, your type 2, is there any difference between a type 1 and a type 2 in manifestations?
Yes.
Not really.
Milder.
More mild.
A little more milder, blamed on other causes, fatigue, recurrent vaginal yeast, prolonged wound healing. Do type 1s also have prolonged wound healing?
Yep.
Yes.
But this might be one of the main reasons they actually come into the doctor for a type 2, because they start seeing a wound that won't heal. Your vision changes. Remember, we can get retinopathy. It can take 5 to 6 years for retinopathy to damage you. But why would we have a need for immediate ophthalmologist evaluation if it takes 5 to 6 years for retinopathy to actually affect your vision?
Because you may have had the disease for 5 to 6 years or more.
Yeah, absolutely. Again, it can take years before you get diagnosed. The damage may already be there. Just a quick review. Fasting blood glucose, 126 or greater on 2 separate occasions. Your random glucose is over 2. Your 2-hour postprandial, over 200. What is our treatment goal when we're treating blood glucose levels that are high?
To get it back down to normal to prevent severe complications.
Yep, prevent the vascular and neuropathic complications. You can kind of see them here, but our 5 components of diabetic management are what?
Education.
Hey, yeah. Nutrition, yeah. Well,
Exercise.
that's the last one. I guess we can go like that. If you want to jump that way. Nutrition, exercise, accurate monitoring, medication, treatment, and editing. Now, why do we have to worry about accurate monitoring? Don't they just have a little cool thing that does it for them?
Well, they could be non-compliant, and you got to worry about scripts being expired.
Yeah, they also could get it from their neighbor. They could get the wrong amount of blood. They could get the wrong strips. They could let the blood actually dry. They could milk their finger. Dietary management, you also think medical nutrition therapy. Why do they need to be motivated when they do this? Can't we just give them a thing of chicken wings and chicken breasts and be done with this?
They need to be able to know what percentage of nutrition they need.
Yeah. They need their optimal nutrition, but they're going to need options. Because if they're not motivated, they're not going to follow it. They need their energy. So give it to them. They need to reach and maintain their healthy weight, prevent fluctuations wide of their blood sugars, drop their serum lipids, and proteins and fats really don't affect their blood sugars much. Don't let them over-control their diet either, because they can go hypoglycemic if they do it. Now, we talked about type 1s being thinner and type 2s being heavier. So what do we probably have to do with them when we're educating them?
Type 1s need to gain weight.
What, you're right? Because they were protein wasting prior to their diagnosis. Type 2s?
They're going to need to lose some weight.
So 5, and remember, when we're talking about meal planning, we talk about 5 children going to Florida to pet 1 dolphin. 5 children from Florida to pet 1 dolphin. So, how many carbs are there in the meal?
50 to
50 to
60.
60.
Yeah, look at that. 5, look at that. That's so nice. 5 children. I like that. What about our fat?
20 to 30.
20 to 30. Yeah, that 2 children, 2 Florida. Yep. And then our protein, 10 to 20. Fiber, and remember, our carbs need complex, one that takes a while to break. Why do we need to give them an exchange list? Why would it help with compliance?
Because if they're eating the same thing over and over, they're going to get tired of it and they won't continue.
Kind of like studying the same thing over and over and over again, right? People get tired of it. Ooh, nothing on that one. Are they allowed to have alcohol?
Yes, in moderation with food.
Unless they're taking what classification of oral hypoglycemics?
Sulfonylurea.
There's one.
And big you man.
The big ones, yep. Which we'll get to. Make sure they eat before they drink alcohol. And of course, with nutritive, make sure you read the labels because adding calories, sugar sweeteners can change their blood sugars. Will change their blood sugars. Exercise, walking, swimming, 30 minutes, moderate aerobic. Lowers their blood sugar. What does it do to insulin use?
It increases it.
Yep. Helps them lose weight. Lowers cardiovascular risk, especially if they're metabolic syndrome. If they use insulin and they're losing weight with exercise, what do they have to do?
They have to have their insulin adjusted.
Yes. What do they have to do with their blood sugar before and after they're exercising?
Well, they have to take it.
Yes. Check it. Prevent post-exercise hypoglycemia. Remember, insulin normally decreases with exercise. Exogenous insulin, if they use this, they should eat a 15-gram carb snack before the mod exercise to prevent hypoglycemia. When should they not exercise?
They have
Their blood sugar's over 250.
Boom. Yep. Blood sugar over 250 in the ketonuria. How do they check their ketonuria? I mean, does it look like something? How do they know they have ketonuria?
There's like a dipstick.
A dipstick. Yep. And again, we already talked about insulin must be adjusted if they're trying to control or reduce weight. And again, watch for post-exercise hypoglycemia. Monitor the blood sugars. Include a 5-minute warm-up, check for blood sugar, include a cool down, and check for blood sugars. If they already have retinopathy or neuropathy, so they have micro damage, they shouldn't be doing major things like weightlifting or heavy jogging, etc. You should have regular daily exercise, a gradual increase, but every patient needs to be unique with their treatments, right? So we need to modify it based on their diabetic issues and cardiovascular issues. If they're over the age of 30 or have 2 or more risk factors, including metabolic syndrome, history of diabetes, obesity, what should they have done?
breast test.
Hey. Of course, gerontological considerations. How are they going to be able to do that exercise? What kind of exercise can they even handle even at their age? This is more of an FYI slide, but remember, blood pressure is just as important as blood sugar for a type 2 diabetic. That blood pressure needs to stay below 130/80. And if it's above that, they need antihypertensives. Your tris need to be below 150. HDL is above 40 and LDL is below 100. Now, we talked about monitoring their blood glucose. Can they do that themselves?
Yeah.
Yeah.
Absolutely. We want them to. What's the advantage of them doing it?
Keep a daily record.
Daily record, new meters used to use, and what else? It lets them feel like they're in
Lets them know
control
if they're
of
gonna
part of their
go.
treatment, right? If they're in control of their treatment or part of it, they feel like they're in better control because they're part of it. Themselves.
Fairness data.
Say it again.
Erroneous data. There may be error. They may not be doing it correctly.
So what's the problem? They got some wrong numbers.
Well, you can give yourself too much medication.
Yep. Also, they could just not do it. They could just write some numbers down and say they were good. How often do they check daily?
2 to 4 times a day.
How often do they check if they're sick?
Every 2 to 4 hours.
Yep, drop the daily, put an hour. Now if they're sick, you say every 2 to 4 hours. Remember, accuracy is based on the reagent strips. What is the name? What is the true name of the HbA1c drug test?
Glycated hemoglobin.
Oh, look at that.
Hemoglobin.
Yes, yes. Measures your blood glucose over a 2 to 3 month period. How does that work? Why does it measure it to over 2 to 3 months?
Because if you come in being good right now, and then it can like go and look at the history.
Right.
and what
We
you
need,
did.
we need to see that, right? We
Right.
need to see how you're doing. How do we know? Like, what does it measure? How can it look back over 3 months?
It's smart. I don't know.
Jen.
Sugar that's attached to the red blood cell.
Whatever. I don't know where you are, but you are not in front of your computer.
Who?
Jenna, I can't hear her.
Okay.
I'm sorry. I may have to reconnect.
Okay, no, I can hear you now. It looks
Can
like
you hear
were
me
trying
now?
to- Yep.
Okay. Is it measuring the sugar that's being attached to the hemoglobin?
There you go, and that's literally what that test is saying. Glycosylated or attached hemoglobin. Glucose is attached to hemoglobin. Glucose and hemoglobin gives you glycohemoglobin. And remember, a red blood cell has about an average of 3 months of a lifespan. So the more glucose, it attaches, it attaches, it attaches. So it gives you a number. We need to stay below 7. Well, 6.8 to 7, right?
Right.
This is not a diagnostic test. What is this testing?
Just your blood sugar level average over the past 2 to 3 months.
Well, that's the definition, but if it's not, but we're not diagnosing with it, why would we take it?
To see how the treatment's working
Right, and compliance.
in compliance.
Mhm. Now, nursing management of the patient with diabetes. We have education. We have diabetic teaching plans. Everybody learns differently, so we need to have videos, and pamphlets, and handouts, and verbals. But no matter what, if we're going to do a physical skill with them, what must they do with us back?
Return demonstration.
Return
Gosh.
demonstration.
Return demonstration. We have to make sure they know how to store their insulin. Select their syringes. Makes their insulin. Here to Cloud. Selecting and rotating injection sites. Know how to inject it. You have to think about availability of injection sites. Should we give them abdominal sub-Qs in the hospital?
No.
Why not? It's fun and easy.
Because we need to save that spot for them.
Yeah, save that spot for them. We got back of the arm. We can go for the butt. We got all that other stuff, right? We got back of the arms. We got places we can go. Let's save that for them, especially when we're teaching them, right? Teach them about diet, exercise, monitoring their blood sugar, how to mix. Make sure they understand what the disease is. Diabetic foot care. Now, a glucometer. What is this actually measuring?
It measures the capillary blood. Is that what you
Mm-hmm. Which is not as accurate as the plasma, but it still gives you that number. Why do you have variations in numbers? What's the most common cause of it?
Bad strips.
User error. Put it wrong. Wrong blood amount. Let the sample dry out. Bad strips is one of the things we want to make sure we stop from happening. Again, QID, sick, Q2 to 4 hours. Now for the fun part, drug time. This is just a quick review. Rapid-acting, Humalog, Novolog, regulars, your short, intermediates, basals, your Rule of 24, your combinations. Now, rapid-acting. Is this clear or cloudy?
Clear.
clear?
Clear. Short-acting?
Clear.
Intermediate?
Cloudy.
Basal?
They're both different.
Ooh, thank you. Ones and one. We've got our two separate ones in there. So, now, remember, if a patient's NPO for our ivory tower nursing of Sacred Heart, NPO, no insulin, right? Now, we got a rapid acting. We don't want to lag behind. What are our three drugs?
Humalog, Novolog, and then one that starts with an A.
Or, again, you don't want to lag behind, Lispro, Aspart, Glucin. These, on all of my slides, will be based on the generic, because that's what we have to know for next year's Hemoclex for now. So, Lispro, Aspart, Glucin. Your onset for all of these, 5 to 15. Peaks, 30 to 60. And durations, 2 to 4 for your Lispro and Aspart. Glucin just has a 2-hour duration. Why do we need to know the peaks in half an hour to an hour?
They can monitor for hypoglycemia.
Yeah, we got to watch for that at that point, right? So if we give it at 0700, when should we start watching for those symptoms?
7:30.
And then of course we go on from there. Remember, Humalogs that, even though these are all there, Humalogs only like to mix, and we have to make sure they get that within 15 minutes. We like to get that preprandial. These are your boluses. Get it in, get it up, and bring that back down. Bring that blood sugar down. So, rapid, don't lag behind. We don't like mixing these. This is a rapid bolus. In fact, I don't think we mix these at all, do we? We give this 2 separate shots, don't we?
Yeah.
Now, our regulars. NPO clears again. The nice thing about regular, they're regular, so they're all the same. Humulin R, Novolin R, 30-minute, 2 to 3, 4 to 6, and this was very nicely put to us. If it's regular, you just count up, 0.5, 2, 3, 4, 5, 6. If you want to write this down at the test, you think about that. 0.5, 2, 3, 4, 5, 6. So we've got Humulin R and Novolin R. And our short-acting regulars. These are your clears. We go to intermediate. What's the name of our intermediate drugs?
Humulin N and Novolin N.
Oh, that was hard. So, but remember, intermediates, the cloudies, right? So here's the ones that you like to mix together. So, onset of your Humulin N, 3 to 4, 4 to 12-hour peak goes through it in a duration of 16. Novolin N, 2 to 4 hour onset, still your 4 to 12 peak with a 24-hour duration. So that last part, before we get to basals, is finally where they got the 24-hour. But they're still peaks. We gotta watch for hypoglycemia, right? Now, just a general idea, giving you a general idea of what we're doing, and we're giving you some, these charts kind of give you what's going on with our levels. Now, our last classification before we start mixing is what?
Basal.
Basal, right? Basal metabolic rate, 24 hours, rule 24. So we want these to start as soon as possible. So we go back a slide. Look at 3 to 4 hours, 2 to 4 hours. We don't like that. 30 minutes, it's a little fast. So what do we want for these?
1 hour.
1 hour. 1 hour is good. Glargine, Dertamir, Mellitus, and Levemir. Glargine is really cool. This is your clear one. Don't mix this. This is your clear one. This is actually fully genetically engineered. 1 hour, no peak, 24-hour duration. Dertamir, 1 hour, no peak, 24, but this is cloudy. But we don't mix these. We pull these up separately. We saw fun questions about that. Your types of insulin, this kind of gives you that general idea, right? Lansin, or your Lantus, your HPN, your regulars, your Lispro. Now, your mixtures. What are the names of the mixtures?
Like the numbers?
Mm-hmm.
50-50. 70-30.
Yep.
And then 75 and 25.
And then 75-25. Now, you can also say your Humulin, then there's your Humalog. So, Humalog 75-25 is your specialty. So we'll do that in a second. But we got 70-30, 50-50, 30 to 60 minute onset. Everything's a dual peak. Everything has a 10 to 16 hour duration on these. 75-25 was that special because it's got Humalog. And remember, on that other slide, back on Rapid, anything mixed with Humalog must be given when?
Was that 15 minutes?
Yep, within 5 to 15 minutes of a meal, preprandial, right? Cloudies. So, do we mix these with anything?
No, they're already mixed.
Mm-hmm. So what classes do we actually mix together?
A clear to cloudy.
Right, which one? So this is cloudy. Do we mix these?
No, they're already fixed.
But you just said clear to cloudy. So which classifications of insulins do we mix?
Intermediate and
Regular.
regular.
Regular. There you go. And look, that's so nice. The names are the same.
Yeah.
So, insulin storage, room temperature for a month, excess, refrigerator for 3 months. Avoid the sunlight. Why do we have to worry about sunlight with insulin?
You can cook it.
You can cook it. It's a
Break it
protein.
down.
Yes, denature. We don't like denatured proteins. We get proteons. Visually impaired, give them pre-filled syringes that are good for 3 to 30 days as long as the needles are stored up. Do diabetics get visually impaired normally?
Yeah.
Retinopathy. They can. They don't take care of themselves. Make sure they can read the labels, and make sure you read the labels correctly, because Humulin N and Humulin R are two different things, right?
Mm-hmm.
Now, alternate methods of insulin delivery. What do we have?
Jet injectors.
Jet injectors, which are fun because literally they're needleless. What else?
Insulin pump.
Ooh, insulin pump. We like those, but people like to abuse those, don't they?
Mm-hmm.
They go out on the weekend, they're like, let's have some beers, and whoop, get those blood sugars up. What else?
Omnipod.
Omnipod, your pancreatic transplant, and of course your insulin pens. Insulin pens. Can you put multiple insulins in those?
They're already made up for you.
Right. So do you have multiple insulins, or are they single insulins?
Single.
Single insulin. Yep. Again, your jet injectors are cool because they don't have a needle. They are literally 0.009 micrograms shot through, and they just get absorbed. Insulin pumps, again, easily abused. So you go out there, you turn it up, you can still get your blood sugar spikes, though, which cause a lot of issues leading to your microvascular complications. Your omnipods, pancreatic transplants. Are the insulin synthetic?
Yep.
Partially, at least, right? So allergic reactions are always a complication. What's the complication of giving the medication?
Alert.
What was that?
You give it in the same spot, you can get lipodystrophy.
Lipodystrophy. We like those lookings, right? Ooh, look at that. Ew. Now, let's say we're sitting there, we start noticing this patient, has issues at night, and then in the morning he gets a really high blood sugar. What's that called?
Your Samoji effect.
That's your Samoji effect. You need to give that snack with a long-lasting carb at night, right?
Mm-hmm.
I'm going to give you a general idea of what this looks like in each day. Drop, bring it back up. Now, what's the next one where literally everything's okay and then all of a sudden they just kind of go hyperglycemic in the morning?
Phenomenon.
Phenomenon.
Phenomenal.
And there's your idea, just putting them next to each other. Dawn phenomenon goes up, and then your Samoji effect. Now don't look at this one. Request the split of insulin dosage to prevent the Samoji effects. So you could give it, kind of keep it there, and then you could give it later on to keep it up. All right. We're going to take a quick break while we're hanging out here. I think everybody kind of needs one, right?
Yep.
We just hit our 45, so let's turn this off. There we go. All right, we are still recording, just so you know. We can't really stop the recording, but feel free to take a break. We're going to take, let's say we'll take about 7 minutes. Bathroom, drinks, etc. People can do what they need to do. All right. Who's back?
I'm here.
Okay.
I'm here.
Okay.
Present.
All right. Just as an FYI, using our information from our book, you can mix a rapid in with your other ones, your intermediate. I was reading an ICU journal and they were talking about removing that. So, but with our information, we are using our clears to cloudy again. Glargin is still not mixed though. That was the other one. So, excuse me on that one. The only other thing we haven't really talked about, which is important to think about, is your selecting of syringes. And it is something we have to think about because it is something we should know, at least teach, because it is something we had to at least mention and was mentioned to us to know. So we have to think about concentrations, units, choosing like our syringes, we'd say 1 milliliter syringes that hold 100 units, 0.5 milliliter syringes that hold 50 units, 0.3 milliliter syringes that hold 30 units. These are all based on our U100s. And there is a U500, but that's based on specialty patients who require a massive dose of insulin due to high insulin resistance. Most syringes have a disposable 27 to 29 gauge needle, about ½ an inch long. Smaller are marked with 1 unit increments and may be easier for patients with visual deficits and those taking very small doses of insulin. And the 1 milliliter syringes are marked in 1 and 2 unit increments. So, just to kind of throw that at you guys to think about while we're going with this. Okay, so let's go back to it and get through these. We're actually going through these really, really fast. So, I'll show you guys some of the drugs and stuff that I'm doing as well when we're done with this. Seeing how the only thing I've gotten done for that is the actual drugs for these. So, okay, so we have our. I should probably actually share the screen though, shouldn't I? Let's see. Let's see. We've got our PowerPoint. Okay. There we are. You guys can see all that?
Yeah.
Yep.
There we go. Oh, apparently somebody has dinged us for using that YouTube clip. So we've got to make sure that I don't use that publicly accessed YouTube clip. Excuse me. Just one minute. Where'd it go? Here we go. And there we go. Okay. All right. Oral anti-diabetic agents. Who's most likely going to be using these?
Type 2.
Type 2.
Yeah, type 2s, right? Why would we give these to type 2s? Remember, our first thing is diet and exercise. Why would we give these to a type 2 then?
If the diet and exercise isn't working.
Hey, look at that.
They still have insulin producing, it just isn't.
Whoa, whoever just said that, you're underwater.
Yeah, that was Casey.
Say that again.
Huh?
Say that again.
They still have insulin producing, right?
Yeah.
Type 2 still have insulin producing. They just need them to stimulate.
Yes, they do. Now, then later on in life have to switch to insulin, especially if they've had this for a long time. The beta cells can give out, but that is a long-term complication. So, but yeah, they have a combination of oral medications they can take. What's the major side effect of taking an oral anti-diabetic agent?
Hypoglycemia.
Hey, look at that. No, it's bad. What's the nursing interventions? What do we need to assess for?
Hypoglycemia.
Oh, look at that. What's, let's see, some side effects we've got. Assess for hypoglycemia and side effects of the meds. And always monitor that blood glucose before you work out. We got the preprandials. You know, we got to check that. How many times a day do we check that blood glucose?
2 to 4.
2 to 4 times a day. Unless they're sick, then it's every 2 to 4 hours. All right. Now, memorization tools. Oral anti-diabetic agents. These are tools that I've used to help us remember these. These are based on the generic only. Use them if you need them, or otherwise if you've got them, you don't have to worry about them. But this is kind of throw them out there to help us. So, based on the generic name, what is our first classification?
Sulfonylureas.
Sulfonylureas, right. So, the sulfonylureas. That's a G with an I, based on second generation. We got a little star here. We'll talk about that in a second. But all second generation sulfonylureas are G with an I when you're speaking generic. The big one we're talking about is glucotrol, but there's glyburide was the other term for it, so GI. Every single one. Now, the second version of this is what?
Non-sulfonylureas.
Non-sulfonylureas. So if we are non-sulfonyuric, get rid of the beginning, you get rid of the beginning. It's your I's without the G. Non-sulfonylurea, insulin secretagogues, meglitinides. Right?
Right. Or they're just the nides.
Yep. Or the nides. Now this will help you when we start talking about first generation. There's the big one-ides, which is the big one in here. What's the big drug there? There's only one in this class.
Metformin.
Yep. And then, of course, we've got one that works, alpha-glucosidase inhibitor, or something that breaks down. Remember, ASE, we break down. Glucose breakdown inhibitors. So, a carbose, or without carbs, and then that guy miglitol that follows him around, AM. And then the last one, the one that's being banned, is what?
The liposomes.
Glitazone. Thiazidiniones. You know how you forget that one? Remember that one? Ends in glitazone, or just zone. Ah! Excuse me. Something just popped up. So back to it. Now, we've got a glitazones. Now remember, anybody on these oral antidiabetics have about a 50% chance of one day needing a type 2 type 2 will one day need insulin. About a 50% chance of needing insulin. Now, back to the star. Sulfonylureas actually have a first generation. The first generation of the sulfonylureas still are I'd. They're just tolazamide or tolbutamide. The ones we're looking at are tolinase and orinase are the actual trade names. You can just use ACE. But if we're using the actual following, you can just use TI'd. GI. Oh, look at that. You may recognize this one too. Diabetes. But these are the two that we focused on. Tolinase, orinase for the first generation of sulfonylureas. And remember, diet and exercise and oral hypoglycemics, and they still have high blood sugar, we're switching over to insulin treatments, right? Or might need a combination. Now, to talk through these general terms. We have our sulfonylureas, tolinase, orinase, diabetes, glipizide, glucosamine, glyburide, glimepiride. See what I mean? GI. Method of action, stimulate the beta cells. What is that targeting?
Insulin.
It's not targeting insulin.
The
What organ?
pancreas?
The pancreas. Yeah, it's causing an increase in insulin by targeting the pancreas's beta cells. You got your oral. Now, you do not want to give oral anticoags, sulfa drugs, anabolic steroids, salicylates, thyroid meds, MAOIs, but you've got to watch it. We want to make sure you're not giving this with hepatic or renal impairment. Here's what I was talking about. If you've got a sulfonylurea, you don't give alcohol. You want to make sure they're not drinking alcohol, they're not a type 1, they're not pregnant, and you do not abruptly discontinue this. Also make sure they're not DKA. Your big one-eyed, metformin. The big one in here, glucophage. Prevents glycogenolysis. Also helps prevent uptake of glucose. This is your contrast thing. Discontinue 48 hours prior to giving IV contrast. Otherwise, you're going to have lactic acidosis. And also after. Again, no alcohol. Don't abruptly discontinue this. What are we targeting if we're preventing glycogenolysis?
The liver.
Mm-hmm. Non-sulfonylureas, meglitides. Remember, end in ide. Ribaglinide, netaglinide. Stimulate the beta cells, different connection spot. Same thing, increase your insulin. Corticosteroids, sympathomimetics, thiazide diuretics, thyroid medications all reduce the effect. Your alpha-glucosidase inhibitors, or starch blockers, again, we have to absorb the glucose. If we prevent the breakdown and inhibit the absorption, we're dealing with the GI tract, right? And of course, we want to stop the carbs, a carb host, maltitol. Targeting GI tract, decrease the absorption. Calcium channel, corticosteroids, diuretic, digoxin. This has a crap ton of meds because it's absorbed in the GI tract. And of course, if it's the GI tract, you're not going to want to give it if they have irritable bowel disease, bowel obstructions, or renal failure. Last class is your glitazones. Pioglitazone, rosiglitazone, Rosie. That's your actose and avandia, increases tissue sensitivity to insulin, and also prevents glycogenolysis. So your tissues, your liver, oral contraceptives shouldn't be given because it actually inhibits this medication. Ketoconazole, what's special about that? Who do we give this to? What endocrine disorder are we studying that gets ketoconazole?
Cushing's.
Cushing's. Remember, Cushing's get a Big Mac. M-A-K. Cushing's get ketoconazole. So watch that. Don't give it if they've got liver failure, heart failure. It's being withdrawn due to bladder cancer and cardiac issues like MIs. Your side effects of your sulfonylureas, again, your sulfa, anorexia, leukopenia, pruritus, photosensitivity, all going to your skin. Sulfa Preprandial in the morning. Then your big one-eyes, diarrhea. Big thing. They don't like this. GI disturbance, metallic taste. And again, lactic acidosis related to that contrast. Monitor the liver and renal functions. This is your bun creatinine baseline, AST, ALT, and recheck it quarter to a year later, half a year later. You take out that sulfur, it all goes to your head. Headache, rhinitis, sinusitis, upper respiratory GI. Headache, rhinitis, sinusitis. If it works in the GI, you're going to have severe GI issues. Warn the patient. And of course, your thiazidinones. Fluid retention, weight increase, myalgia, increased LDLs, and upper respiratory infections. What's your major side effect of all of these?
Hypo.
There's the hypoglycemia. The Christmas hypoglycemia. Now we have 3 other special classifications. We have dipeptidylpeptidase 4 inhibitor, amylin analog, and incretin mimetics. And this Invokana is not an incretin mimetic, but I just threw it there so we can think about it for a minute. But what does stress do for patients who are taking a PO med like this? What line do we have to switch to?
What did you say?
If a patient is under stress who normally takes the PO med, like sickness, what might they have to switch to?
You have to switch to insulin.
They may have to switch to insulin, at least for a short period of time, right?
They
Now,
can't keep their meds down, yeah.
we've got dipeptidylpeptidase 4 inhibitors. Januvia, linagliptin, Onglyza. They enhance the incretin hormone, which increases your insulin, decreases your glucagon. Incretin is a hormone that's in your GI tract that's released when you have too much sugar. And they go up to your pancreas and say, all right, we need more insulin. Drop the glucagon. We don't need that much. Combinable with metformin, upper respiratory infections, sore throat, headache, diarrhea, and pancreatitis. So if we need insulin, you can give J-Lo for the dipeptidylpeptidase 4. These are your PO meds for this one. You've also got your parenteral agents, which is your amylin, Simlin. If you think about amylose or amylase, when this actually drops down for amylase, your stomach and your digestion actually slows down, so it gives you time to digest it. So you give this, it actually slows your gastric emptying, decreases glucagon level, and increases that feeling of being full. Sub-Q abdominal thigh, heart and renal disease, pancreatic and thyroid cancer issues. And the last one is the incretin mimetic, which is your Byetta. Decreases gastric emptying, increases insulin, prevents postprandial glucagons, decreases your appetite, again, sub-Q postprandial, preprandial, breakfast, dinner, nausea, weight loss. The last thing is that Invokana, which has a whole special classification we're not studying right now. But Invokana does what with glucose?
It dumps it through the kidneys.
Yes. Dump it out. Prevents absorption, inhibits reabsorption, you get glucosuria. Of course, side effect of that is dehydration and UTIs. Because glucose loves the water, right? Hypertonic. So, just a general idea of what's going on with that. So, you glyburide, your metformin gives you something like glucagon, so you can combine and get your names. General meds need constant blood glucose checks when we're doing our checks, right? 2 to 4 times a day. What do we have? Remember, this is a lifetime thing for them. What do we have to educate them on so they can actually master and know about their disease, besides, how to give their medications? What do they have to look for?
What their normal glucose ranges are.
Signs of hypoglycemia.
Yes, their levels as well as signs that things are going bad. whether they're not eating enough or over-controlling or not controlling enough, as well as infection control. We talked through this whole thing already for you, but where the classifications of drugs work for you, where your targets are. I'll give you a general idea. All right, your acute complications of diabetes. Before we fall way too far one way or the other, what's the first thing you're probably going to see if somebody doesn't eat enough, or they're not doing their medications right, they're not taking enough?
Hypoglycemia.
Or taking hypoglycemia. Where are you most likely going to see hypoglycemia? With somebody who's taking, a sub-Q shot. When are you going to see it with somebody who's taking insulin?
Oh, at the peak?
That's your peak, right? You've also got your DKA and your HH&S, right? So let's do each one of these in order. Hot and dry means you're high, cold and clammy, need some candy. Less than 50 to 60 blood sugar. What's up with your insulin? High or low?
High.
It's high. For hypoglycemia, you've got no sugar ready. You got a high oral hypoglycemic agents, low food, lots of physical activity, right? You can have that post-workout. What are your symptoms going to be based on adrenergic or adrenaline-based symptoms?
Sweating.
What's sweating?
Diaphoresis.
Hey, I like that.
Tremors.
Tremors.
Palpitations and tachycardia.
Tachy. Nervous. Hunger. So let's look up here for a second. Remember, we've got hyper and we've got hypo. There are some symptoms that kind of go together on both of those. But there's a few that kind of separate. Look at shaky. Look at fast heart rate. Which one of these would be hypoglycemic? Only. We're talking hypo versus hyper right now. These two.
Shaky.
No. If you get enough sugar, what's going to happen to a 10-year-old if you give them enough sugar?
I mean, they'll be excited, but won't they be like, I don't know,
You can still
more
consider,
lethargic?
you can still throw shaky into hyperglycemic, but you can see a fast heart rate when you're throwing in hypoglycemic. If you're looking at hunger versus anxious, which one are you going to see in hypoglycemic? Only.
Anxious.
There you go. Sweating versus dizzy. This one's a little more interesting.
Busy? Oh, cold and clammy, you need some candy. Sweating.
Dizzy is also something you're going to probably only see in hypoglycemia, but you could see it based on hyperglycemia, based on the symptoms that are occurring. These are just some things to throw out there to think about, because irritable, anxious, fast heartbeat, and sweating are some of the big ones you think about when you're thinking hypoglycemia. Now, these other ones are part of it. But these are the ones that can help you differentiate hypo and hyper to kind of pull it apart as a quick guide. What am I looking for? I'm looking for that quick change in mentality, the skin change, that heart change. Remember, the brain needs glucose. Hypoglycemia. CNS symptoms: loss of concentration, headache, confusion, irrational combative behavior, forgetful, slurred speech, numbness of the lips, the tongue, diplopia, drowsy. And your symptoms of severe hypoglycemia are what?
disoriented.
Seizures
Seizures.
and like coma, loss of consciousness.
There you go. Stop them before they get here. Who would you give? When would you give these patients IV D50W?
When they're in the hospital.
When they're unconscious.
When they're unconscious. If they're, let's just say they're a patient who's, a diabetic, you don't know that they're hypo or hyper, we don't know what's going on, and then they're unconscious. Are you going to give them I50, are you going to give them the D50? You know they're unconscious, but you don't know if it's hypo or hyper.
Yes.
No.
Yes, you would.
Yeah. Okay.
Because hyperglycemia is a slow onset of issues. Hypoglycemia is rapid.
Okay.
So if you give it to them, they're going to wake up if they're hypoglycemic. If they're hyperglycemic, you just gave them a little more sugar. It's fine. It didn't work.
Okay.
All right, remember, with hypoglycemia, we need immediate treatment. Give them 15 grams of a fast-acting concentrated carb. We did 4 glucose tabs, 4 to 6 ounces of juice or regular, not diet soda, 6 to 10 hard candies, 2 to 3 teaspoons of honey. Once we've done this, we found out they were low. What should we do once we've done this for them?
Check your blood
Check
sugar.
your blood sugar.
Yes, retest it, 15 minutes. If it's below 70, repeat PRN. What happens if we don't have a glucometer to check?
Just continue until
Retreat
signs and
again.
symptoms are no longer there.
Treat until the symptoms are gone. Once it's to a normal level or their symptoms are gone, what do we do?
Give them a snack with protein and carbs unless they're going to eat within 30 minutes to an hour.
Yeah, meal within 30 to 60 minutes. Make sure they're going to do that. If not, protein, carb. What type of carb?
Complex.
Complex. Keep it up there, right? All right. Emergency! Oh no, they fell asleep. They're unconscious. They can't swallow. Now what?
Give a shot of glucagon,
A lot of glucagon. How much?
1 gram.
And where?
Sub-Q
Or?
or IM.
So we've given them sub-Q or IM. We can also give them what?
Dextrose solution through their IV.
We get our 50% dextrose IV. How much?
25 to 50.
Yep. And of course our sublingual icing, right? That'd be a nice thing to wake up to. Now, those are fun. Let's do our not so fun ones. Diabetic ketoacidosis. What's going on with our insulin with this?
You don't have any insulin.
Very low or no insulin. Lots of counter-regulatory hormones. You get a counter or abnormal metabolism of your carbs, fats, and proteins. Clinical features. What's your blood sugar going to look like with this?
Between 250 and 800.
Are these patients, what are their fluid levels like?
They're dehydrated.
Hydrated.
What's in their blood and what's in their urine?
They have ketonuria.
And?
Those.
Ketonemia.
Oh, okay.
Early symptoms, of course, is your abdominal pain. You get nausea, vomiting, sudden weight loss. That's your big one for your early symptoms of your DKA. So don't forget, hyperglycemia, 250 to 800, dehydration, acidosis, ketonuria, ketonemia. You've got to get your ketones if you're going to go acidotic. Assessment, acetone breath. You already said 250 to 800. Will this change? Like, let's say I have a patient DKA with 400 versus a patient DKA with 785. Is that going to tell me a difference in the difficulty of that DKA or how strong it is?
No.
Not related to that blood glucose levels. So, the acidosis. What is my bicarb going to be? High or low?
Low.
Low. What's my pH going to be?
Low.
And late into it, what's my CO2 going to be?
Low.
Low, due to the compensation. If it's early on, where they just went into it, this could still be normal. Based on what's going on, they could need electrolytes, could be varying according to water loss, level of hydration. All right, your symptoms here: polyuria, polydipsia, anorexia. What's the breathing pattern like?
Small.
Moles, mental status change, headache, blurred vision. Huh. I wonder who has this. Okay. Blurred weakness, acetone breath. Prevention, sick day rules. Should they take their meds every day?
Yep.
Should they take their meds if they can't hold their meds down orally?
No.
Yeah, they should take them. What happens? But if they can't hold them down, what's going to happen?
They need to call their doctor.
Yeah.
They'll probably be switching to insulin for a little while while they're sick. What happens if they can't hold food down? Or they're not hungry? How do we make sure they get their caloric intake?
Liquids
How often?
every hour.
There you go. You see.
And it needs to equal their caloric intake, right?
Yes, it does. Remember, if you're unable to eat your regular meals, eat small, frequent amounts of carbs, carbohydrate foods every hour, such as 6 ounces of soft drinks or fruit juice, a third cup of sweetened gelatin, half a cup of ice cream or sherbet or cooked cereal, 1 cup broth-based soup or cream soup, a slice of dry toast, 6 saltine crackers. This is every hour. Non-caloric beverages should be drank as tolerated. And try and prevent the issues as much as possible. Besides their DKA stuff, besides their normal hyperglycemia, we also have some other issues they should be looking for, mostly related to those DKA. Look for pains in the stomach, that acetone breath, difficulty breathing, Kussmaul's, diarrhea, vomiting, rapid weight loss, the unusual sleepiness, or trouble paying attention. What does stress do to your blood sugar level?
Raise
Goes
it up.
up.
Raise it up. What happens to your, do you get, let's see, how often should you check for ketones in your blood when you're sick?
In your blood?
In your urine, excuse me.
Every 4 hours?
Every 4 hours. Prevent this. Diagnose and get treatment for your diabetes so it doesn't happen. Call your doctor if your blood sugar goes above 250 and assess for the underlying causes of this. Treatment for diabetes, or for your diabetic ketoacidosis. What's your first big tube?
Rehydrate.
Rehydrate with IV fluids and
Insulin.
what type of insulin?
Regular.
Yes, infusion. Reverse the acidosis, the restoration of electrolyte balance. Remember, if you're rehydrating, you're going to increase the plasma volumes, which will help that potassium lower. Insulin moves potassium back into that cell. If we have potassium issues, we need to make sure we have that EKG. Watch electrolyte issues. Blood glucose, renal function, make sure that urinary output stays at above 30. Vital signs, lung assessments, signs of fluid volume overload. Watch for that. Your hyperglycemic, hyperosmolar non-ketotic syndrome. What's going on with insulin here? Do you have insulin here?
Yes.
Yes, you do. But so ketosis is minimal because you've got something that resists that, right? You just don't have effective insulin. So you're hyperglycemic. Are you holding your urine or are you peeing it out?
You're peeing it out.
Osmotic diuresis. Loss of fluids and electrolytes. You become hypernatremic. Increase of osmolarity occurs. If you lose your fluid, what happens to your blood pressure?
Decreases.
Yep. And then you become tachycardic. Dehydrated. Neurologic issues. Which one has a higher mortality, DKA or HHNS?
HHNS.
Yup. Treatment, same idea. Rehydrate, insulin, monitor fluid electrolytes. Prevent with self-monitor blood glucose. Diagnose and treat. Assess and promote yourself. Quick review, ketoacidosis. Hyperglycemia for DKA, common in type 1, versus your severe hyperglycemia and no ketoacidosis with type 2. So, blood sugar is 250 to 800, rapid onset in DKA. Your ABG's pH is below 735 because your ketones are present. You can forget your insulin, have a physiologic stress. With your HHNS, you have a blood sugar over 600, slow onset. ABGs are normal, no ketones, physiologic stress. So between the two, why do you think DKA is less deadly than HHNS? What's your body doing in DKA that HHNS is not doing?
Your body's trying to compensate in DKA.
Mm-hmm. You're dropping the pH, you're breathing differently, you're trying to handle it. HHNS, your blood sugar is just going up and your body's just every day, right? Normal everyday occurrence. DKA, rooty breath, ketonuria, ketonemia. Look at this. DKA has DKA. Dehydration, Kussmaul's, acidosis, rooty breath, ketonemia, ketonuria. Low mortality rate, because high mortality rate, but you also can have dehydration here. Almost there. Almost done. Oh my goodness. Remember, your complications can be macro or microvascular. We're talking macrovascular. What are we talking about?
Talking about issues with your heart and your brain.
Heart and your brain.
The big ones.
So, atherosclerotic changes and makes it fast. Coronary artery disease, peripheral vascular disease, cerebral vascular disease. You've got your micro, which is your diabetic retinopathy, nephropathy, peripheral neuropathy, autonomic neuropathies, hypoglycemic unawareness, diabetic retinopathy. Microvascular includes your nephropathy, just an idea for next time, increased proteinuria, and stage renal disease can happen with that. So we need to control that blood pressure and those blood sugars early. Retinopathy, lots of little vessels that can be easily become occluded. Neuropathy is lots of little stuff, but your general idea is you start losing feeling, start losing everything, start having xerostomia, leads to your diabetic foot ulcers. Coronary artery disease, silent MI. Cerebral vascular disease, your stroke, your TIAs. PVDs, you've got mostly an arterial issue. You've got poor circulation, ischemia, cold feet, intermittent lameness and pain. Assess the pedal pulses. Because what's the end result if we don't take care of the peripheral vascular disease?
Amputation.
Amputation. Mmm.
Ugh.
Yum. The lack of sensation, right? Foot care. Wash your feet with mild soap, lukewarm water. Dry your feet well, between the toes especially. Can you use lotion?
Yes.
Between toes.
This is not between the toes. You want to use lotion too, right? Check your feet with somebody there, or of course your mirror. Can you use a nail clipper?
Yes, as long as it's a straight edge and you're not rounding it out.
Yup. Socks. Can you use socks that have patches in them?
Not with patches.
You need
You
clean,
don't
dry
want seams.
socks. No seams. Keep your feet warm, dry. Never walk barefoot. What about the beach?
Nope.
Nope, you gotta wear shoes.
Okay, but your house is okay, right?
Nope.
Nope, you gotta wear shoes.
What? That's my house. Yes. Doesn't matter. You can't feel it, right?
You can step on a thumbtack and then lose your foot.
Examine your shoes. Now, what happens if I go to get my shoes? How do I make sure they fit? Because I can't feel them. Besides asking somebody to do it for me.
Oh, you can draw a circle around your foot, like an outline of your foot.
And then, of course, make sure there's room for it to go. You need a little, a good half-inch in front. Let's see. Is that? You could need a good half-inch in front of it, good for your toes to wiggle. Make sure it draws around it and fits on the bottom of that shoe. Make sure you inspect the shoe. But as nurses, we also inspect the shoe when they're coming. Look for blood. Look for anything in the way there. Any signs that something's going on. Whee! Okay. So that was our diabetes. So I'm going to end this broadcast on this part right here. Thank you guys for helping me with that one.